prominent rheumatologist down there and has this blog for rheumatologists called Rheumatology Now. And there's an interesting article recently that talked about the fact that, we should be screening more patients with psoriasis looking for their arthritic issues. A lot of people don't realize it can cause swollen joints and back pain and be associated with inflammation of other organ systems. And I think when people run into dermatologist's office or their family physician, they just want something to make that silly rash go away. It's not so silly. It's pretty devastating for a lot of people. And I think up until recently, there really haven't been as many effective treatments as we've had in the past, that we've not had in the past. I've been around long enough. I predate the biological era by quite a few years, and so I know what it's like to treat people with psoriasis and without any of the tools we use today, and many of the other clinical illnesses that are associated with psoriasis. I'll show you some pictures of. I had about umpteen thousand slides, so I decided you guys didn't need to see a lot of crazy looking x-rays, so I cut most of those out a few minutes ago.
Were you with the Arthritis Center when it was over on South Street at 56?
Yes, I was.
Back then? What year did biologics? You said you were before them. What year
Yeah.
did they come?
Not till the mid-90s.
90s.
Yeah. They were early, they started being developed in the 90s. Tanacept was the first. And after that, several other TNF inhibitors like that came along, and within the next few years, Remicade, Humira were the three for quite a while. And in the last 4 or 5 years, we've had the addition of Cimzia and Simponi. They all have the same mechanism of action and slightly different molecules with slightly different amounts of medicine per injection. Some are monthly, some are weekly, some are every 2 weeks, and some are intravenous, particularly Remicade and Simponi area. So we have some options for administration, and get to play games with insurance companies and Medicare about who gets what. But they're amazing drugs. The thought of being in this planet without biologicals, the rheumatologist would certainly not. Am I doing something wrong?
Push that button there. Up. No, right there. Not working. There it goes.
There we go. But I've had the really good fortune of being around Dr. Weaver and I, and started the development of clinical research program in our center many years ago, when we were part of the group of clinicians around the country and around the world that took on the task of doing early phase 2 studies. Only about 50 people had been on the product just to see if it was relatively safe and look at the biochemistry of the drug. And then that mushroomed, and that particular clinical trial lasted 15 years. It was interesting because it was early rheumatoid arthritis without the addition of any other immunological products, like methotrexate or just straight Enbrel, and it was catching it early and hitting with that drug was phenomenal. And subsequent studies, around Enbrel and all the other TNF inhibitors looked at psoriatic arthritis and psoriasis and ankylosing spondylitis and Crohn's disease, all of which have this collective genetic predisposition, many targeted with the genetic code called HLA-B27. Well, let me show you a few pictures. Since most of you know what psoriasis looked like, but I was always surprised. I ask a lot of patients, "Do you have psoriasis?" They look at me like, I don't know what that is, and I've never heard of it. So it's not a real common illness, despite what I see enough of it that I'm quite familiar with it. Obviously, it's a red, scaly, itchy, not very pleasant thing to have. Thick plaques typically appear over the extensor surface of the elbow, the knees, the lower back, sometimes the sternum, oftentimes in the scalp. So there's a lot of areas that it has a predilection for. This is a big, large plaque on a patient's leg. It can be inverted. Some people get it in intertriginous areas under the arm and the groin and the intergluteal spaces. Not a terribly pleasant place to have it. Even in the umbilicus, and we always check that little spot. I think many times people come in with atypical arthritis, and if we look hard enough, sometimes we just haven't found that little bit of psoriasis that might be there. So I try to take a careful look at, what isn't obvious rheumatoid arthritis, and all the blood tests say it's not. Look hard for skin lesions, nail lesions, anywhere and everywhere. You really do have to undress the patient and take a careful look. In the ear, sometimes that's the spot you'll miss it if you don't look for it. This is a pustular palmoplantar psoriasis. This is a tough bird to treat. Before we had biologicals, I failed miserably helping people with this. This is so-called guttate, the little smaller plaques, papules. They look almost acneiform sometimes. They get mistaken for a lot of different things sometimes. This is nail pitting with nail breaking down. It's crusting. That's pretty obvious. Most of the time when I find this, it's just a lot more subtle than this. There'll be a little tiny pits, maybe one or two little splinter hemorrhages, little black spots out at the end of the nail. Sometimes you'll see a little red-pink spot under the nail. And then sometimes the nail lifts up, an item called onycholysis. These are the red spots underneath the nail. Sometimes they're more on the back. Sometimes you get white spots called leukonychia. You get little, it looks like somebody, you must have bumped it, but it's not. It's just part of the psoriasis. You get little white spots. But you can see how the coloration changes. And sometimes people think they have a fungal infection and ignore it. When it's in the toes, sometimes it's hard to tell the difference. You're more apt to see fungal infections on our toenails than you are fingernails, but that's real obvious psoriasis of the nail. So I think the biggest issue about psoriasis is, what part of your body is it on? How exposed is it? How do you live with it emotionally and physically? I have some guys who wear their Bermuda shorts in the middle of winter just so they get some UV on their knees and keep their legs clear. Obviously, when it's anywhere above and beyond 5 to 10% of the body surface, that's very, very significant serious disease. And it has systemic symptoms associated with it. People can actually get fever and febrile, and they get really sick. People don't always recognize that. When I was at Mayo Clinic years ago, they had a floor over at Methodist Hospital next to the main part of that campus, and they had a whole wing of this floor, and they used to do tar therapy. It was called Geckerman therapy. Anybody heard that term? It's they literally had this whole suite, and these people were painted down with this tar. I mean, they were just walking around, and they had these brown pajamas on, and they were brown for a lot of reasons. It matched the tar. And they literally were treated with this tar and with UV lights for 2 weeks straight as inpatients. But the interesting thing about it was effective for a long time. It would be terribly expensive to do today, but in that setting, but it would put people in remission for 6 months to a year. Some people just had their yearly visit. It was their, week at the spa at the Mayo Clinic, psoriasis unit, but it actually worked. I think the cost of this thing is this illness. When he looks at the biological, that's the thing. Most people are not satisfied with how they feel. People with a little less significant disease tend to ignore it more and are dissatisfied. They don't like the fact that people are giving them topical therapy and they got to do it twice a day and do all the jumping through the hoops to make it look better and make you feel better. So there's a high rate of dissatisfaction. Interesting thing is people with more severe disease are more actively seeking better treatments and they're more satisfied. So a little bit of psoriasis keeps you unsatisfied, it seems, based on the statistics I was reading in another article. So the topical therapies, many of these have been around for many years, and I don't have a lot of personal experience with them except for the fact that a good emollient helps, Eucerin cream. I think the Mayo Clinic owned stock in the Eucerin company in those days, because whatever you put on first, you put Eucerin cream over it and large gobs of it, and kept things soft and comfortable and less itchy. has a lot of mineral oil in it, and so it helps. The corticosteroid therapies that you buy over the counter are usually not effective. You need something much stronger. Items like, clobetasol, for example, which comes in a little can, and I love that stuff. It's activated. It's great for a little bit of eczema, dyshydraulic eczema on your fingers, as well as psoriasis. It's a little pricey, but it really works. It's clear in color, so it penetrates well, and it really is a nice product. I've not had any experience with tacrolimus, but it helps in the facial area, where you don't want the steroid side effects over time, thinning of the skin and the discoloration associated with steroids, and in skin folds like that inverted psoriasis, because it's not so irritating. The retinoids, there again, I've not personally used those. Anybody in this room ever used a retinoid? I don't see it prescribed by, I've never seen a patient walk into my office taking that product. And of course the UV lights, UVB is helpful, and particularly in combination with some of the applications and then there was the Psoriasis-induced UV light process that I'm not sure how much that's being used anymore. Is anybody here doing that? Has anyone ever done that? UV lights with Psoriasis, so that you take this tablet, it makes your skin more sensitive to the UV light process. That used to be quite popular. There used to be a lot of UV boxes in dermatology offices. I don't know how much of that happens anymore. I'll have to start talking with those fellows more. I think in terms of systemic therapy, the psoriasis does respond somewhat in the skin to methotrexate. Methotrexate doesn't do very much for psoriatic arthritis, but it does help the skin. Of course, that whole story over the years, many years ago, was given orally on a daily basis, and that goes back into the 60s and 70s, and people were developing cirrhosis of liver because they didn't realize that daily dosing of methotrexate could cause liver damage. So it's not given in that manner at this time. It's usually given pulse doses once a week, and that works pretty well. Cyclosporin is another immunomodulating product. Works reasonably well some of the time. Some of the dermatologists in town seem to like it. I see it written on some of my patients. We use it in rheumatoid arthritis and rarely. We can't find anything else to do, but it's not a great drug for rheumatoid arthritis. Premolast is a new non-biological product, which I'll talk about a little bit more detail later. It's an oral product, which is nice, and it does work reasonably well for the skin, works fairly well for the arthritis, but it's not recommended people that have advancing destructive arthritis because it hasn't been proven to slow down the destructive arthritic condition. And of course, there's the biological products, the TNF inhibitors, the interleukin 12, 13 combinations, the IL-17s, and that's the new kid on the block that I think is pretty exciting. So by definition, if you have psoriatic arthritis, you have psoriasis. Typically, rheumatoid factor and CCP negative. In fact, when we're doing clinical trials, the research companies insist on it, and that can be positive, even though once in a while you get a false positive, low-grade rheumatoid factor positivity or even a CC positivity. But that's usually pretty clean and clear-cut. Most of the patients who have typical psoriatic arthritis are what we call blood test negative or seronegative for the rheumatoid markers. It's not genetically predisposed to one gender or the other. The incidence is, not real common. It's far less common than rheumatoid arthritis, for example, in terms of the arthritic component. Only about 10 to 15% of people with psoriasis develop frank arthritis, although I think most of the rheumatologists are beginning to think that's probably underestimated because it's just not being looked for regularly. And we've had patients who have developed the typical dactylitis or a sausage toe or any number of features of arthritis. Oh, this has got to be a psoriatic arthritis, just looking at it because where it is, what it looks like, and yet several years later, we finally see psoriasis. People that are seronegative for rheumatoid factor and CCP make up a group of things that kind of have a common denominator, that many of those patients are B27 positive. That's a blood typing genetic code that's very strongly positive in people with inflammatory spine disease, ankylosing spondylitis, But a lot of people don't realize that psoriasis and psoriatic arthritis can be associated with inflammatory spine disease, can be associated with Crohn's disease, and psoriasis all in the same individual. And then you throw iritis in there. I remember not some years ago, I had a young man from, I think, Waco or York or somewhere, and he had all of it. He had ankylosing spondylitis, nail pitting, Crohn's disease, and iritis. He had the whole package all in one. So he was a textbook case for a med student to go in and learn about B27 positive disorders. It's strongly positive ankylosing spondylitis to the degree of 95%. And ankylosing spondylitis is genetically predisposed to males, about 9 to 1 over females. But in people that have psoriasis, that B27 positivity rate is far less. But if they happen to have spondylitis and psoriasis, the incidence of B27 is a bit higher than the normal population, which is 88%. But nowhere near 8% of the population has either psoriasis or ankylosing spondylitis or the combination thereof. So that's an interesting bit of, there's some relationship, but it's not a one-to-one relationship. And a lot of these individuals have a lot of tendonitis and tendinopathy, tendonitis problems. That's called anisopathy. I'll show you some, and it's definitely genetic. So to make the diagnosis, you find swollen joints. That has to be well documented. It has a typical distribution. It's often seen in the distal interphalangeal joints at the tip of the fingers. When you see nail involvement, distal involvement in those joints is frequent. Usually there's quite a bit of morning stiffness, not just a little bit of 5 to 10 minutes. It lasts quite a while, a minimum of 30 minutes, typically more than an hour. So there are no lab tests that are very specific for it. Again, the blood tests for autoimmune disease are typically negative. If they're positive, they're probably false positives, and they're not related. When people are sick, their cell rate's elevated, they have an elevated CRP, they may have a high white count, they may be anemic, they may have fever. They get really toxic, and if they get a superimposed bacterial infection in their skin, they get really sick. These are those diseases we've been talking about. I don't think Behçet's syndrome really belongs in here. It's not at all related to psoriatic arthritis and B27 disorders, nor is Whipple's disease. But everything else up there is. Reactive arthritis is post-infectious related arthritis. We'll talk about that a little bit later. So the patterns, 20% have distal joint involvement. That's a tip-off. Rheumatoid arthritis patients don't typically present with DIP involvement in a rather exclusive way. It's usually very asymmetrical. It may just be a handful of joints, 3, 4, 5. It may be symmetrical and widespread and look like rheumatoid arthritis on occasion with wrist, MP, PIP involvement, and spare the DIP joints. So it can be a little confusing in the beginning. It can be very mutilating. Some of the worst arthritic patients I've ever had in my experience on this planet have been these psoriatic arthritis with multiple joints. Remember this one gentleman from Columbus, I mean, he had everything was replaced. It was just a mess. It was back in the days when we had nothing to treat these people with. He happened to be very responsive to one of the non-steroidals that was pulled off the market years ago. It was the only thing I ever took his cell rate under 100. I kept saying, why does it work in this guy? It was, and he had a cell rate, so typically 100, 120, 130. Everything was swollen. His skin was a miserable mess. And he had a lot of deformities. But none of the products we had in those days did anything for him, except for that one remote NSAID came off the market. He wasn't happy about that. Well, here's the nail involvement and distal interphalangeal joint involvement. You can see the middle finger on the left hand is quite swollen. This fusiform swelling you see in that fourth digit is asymmetric with the right hand. So there you see DIP involvement, asymmetry, fusiform swelling, and psoriasis with nail involvement. There's no guesswork there. That's psoriatic arthritis at its best. Another example, lots of erythema. You can see the psoriasis on the back of the skin. Again, a lot of DIP involvement and asymmetry. His left index digit compared to his right index digit are clearly different. That's the worst thing for people, I think. The DIP involvements like this. And that's one thing these new products make better, a lot better. So here's a patient again. This one doesn't show any psoriasis on his skin, but I think he's got a nail or two that are involved. His skin looks pretty good, but you can see his right index finger, right middle finger is a bit swollen. His wrists are a little bit swollen. Somewhat symmetrical, but not really. His right fifth PIP joint is making that finger crooked. It causes a lot of contractures and deformities, and you get these little fingers are basically, when you look at the x-rays of this individual, the bones at the joint are basically dissolving. It's called deformans, is an old Latin term, an obvious deformity. So you can see this in rheumatoid arthritis, but it's less common. We see it more often. The worst case I've ever seen it was in a young woman who had juvenile idiopathic arthritis that lived to be an adult. When she was young, her fingers just dissolved, her bones just disappeared. This is a fellow I take care of presently, and he's doing pretty well, but he's had this disease long enough that he has literally fused his distal inflammatory joints, his MCP joints, and he can move his MPs a little bit. So he kind of works like this, kind of like got a claw hand. And he's also got hyperextension of his PIP joints in the left hand. That's kind of rare in psoriatic arthritis in my experience. You can see the swelling through these MP joints are just really, really puffy. That's what his skin looks like. I can tell you when we put him on Humira, that all went away. Here's a case of this, an X-ray shows sacroiliitis. This is the B27 connection. When the sacroiliac joints of this person are basically gone. There should be a little dark little line coming through there, but this bit they're fused. This is earlier in the course of events, but again, it's real ragged looking. It's usually a little smoother. You don't get these indentations. You don't get that sclerotic white bone on both sides. In spondylitis related to psoriasis, it's a little more asymmetrical and typical. Ankylosing spondylitis is quite symmetrical. You can even see that the symphysis pubis region is reactive. This is another sign of spondylitis, that reactive bone. That didn't happen because of an injury. That happened because of the inflammatory process at the ligament attachments in those joints. And the spine over time, vertebralitis wear off to lose that slight indentation they typically have in the front. They kind of expand and just become very square. And over time, the anterior longitudinal ligament totally closes off the spaces and is basically totally fused. We call that a bamboo spine. That's an front anterior look or front view of that same spine. The syndesmophyte is fused and they're fairly close and vertical. In the joint process, the spurs flare out and don't close. Except there is a condition in mostly males, mid to upper age males and females, where you get a lot of overgrowth of bone, and it's sometimes confused for spondylitis, but it's called DISH, disseminated idiopathic skeletal hyperostosis. I call it the dinosaur disease. Dinosaurs in their neck, because of their heavy, long necks, develop extra calcification within their spines to hold their heads up. And so this is bamboo spine. I didn't bring a picture of this other, but the spurs are far different in appearance. But I do see that sometimes confuses some physicians when they haven't been familiar with it long enough. So this tendon issue is real common in psoriatic arthritis and dactylitis, what we call a sausage toe. A lot of flexor tendonitis, Achilles tendonitis, very common. Here's an example. The left Achilles tendon you can see is much fuller and thick, and that whole tendon is swollen and inflamed. This is dactylitis. This is the sausage toes. Again, you can see that we have psoriasis of nails and distal inflammatory joints. When that walks into my office, I've got a pretty good clue what I'm looking at without much trouble. And this is what happens to the joint. It starts off, this is the only disease that causes joint space narrowing combined with overgrowth of bone simultaneously. You get this flaring, what we call juxtaarticular bone growth. The joint starts to narrow, disappears. and then it dissolves. That only happens in psoriatic arthritis. And rare cases of Reiter's syndrome, which is another post-infectious form of arthritis that can look a lot like this, and even the skin lesions can look like pustular psoriasis. So, look for nail lesions, look for swelling, look for ocular involvement on occasion, look for any sense of back pain. This is an individual with uveitis, related ankylosing spondylitis, but we see this in psoriatic arthritis as well, same image. You see nail dystrophy, you'll have a high incidence of arthritis, much higher incidence. So again, the lab studies are non-specific, none are diagnostic. And how do you treat this bird? Well, these days, since the TNF inhibitors came along, it's been much more easily managed. Every one of these products has appropriate studies and indications for management of rheumatoid arthritis, ankylosing spondylitis, and in psoriatic arthritis, not to mention psoriasis itself. They inhibit a pro-inflammatory cytokine, a little protein, that is being manufactured in excessive amounts in people with inflammatory forms of arthritis. It's actually higher levels in rheumatoid arthritis, but it's quite high in psoriatic arthritis individuals as well as those individuals with spondylitis. It basically is telling cells to move to the point of attack. They're like messengers on the internet, telling the bombers to take off and go find their target. The antidote are the antibodies that are cloned in animal models, genetically modified to create a single monoclonal antibody directed against those pro-inflammatory cytokines. And this particular cytokine, meaning cell movement, cytokinesis, is TNF. It's one of the major cytokines. The others are interleukin-1, and in psoriatic arthritis, one of the big issues is interleukin-12 and 23. And Stelara has been around for a while. That's popular with the dermatologists. Rheumatologists aren't as fond of it in treating the arthritis, because we think the TNF inhibitors work better for the arthritic component. But its target is interleukin-12, 23, two different targets. Cosentyx is one of several new interleukin-17 inhibitors that are in development. This one's the first on the market. There's another one called ixekizumab that just came on the market. It's been approved by the FDA, but it hasn't hit the market yet. I haven't seen anybody detailing it in my office. It is one of the products that we've helped develop as well. We've been working on, I think the only biological I haven't worked on in this entire list is Stelara. The dermatologists have that one. But Cosentyx is very effective. I've seen it working extremely well in my clinical setting, and it works for these psoriatic arthritis very nicely, as well as some individuals with rheumatoid arthritis as well. But we've primarily been focusing on using it in psoriatic arthritis. In psoriasis, it's given 300 milligrams weekly for 4 weeks, then monthly. In psoriatic arthritis, it's given weekly at a slightly lower dose, and then monthly for reasons that aren't clear to me. But the caveat is if it's not working at 150, you can bump it up to 300 milligrams on a monthly basis. This is an interesting product, kind of a novel idea. One of the intracellular key items of our cells is a thing called cyclic AMP, and that's like the little generator that keeps the motor running inside our cells. It sort of creates a lot of the activity, and that activity stimulates a lot of these cytokine products that stimulate inflammation. And if you slow down that cyclic AMP, you reduce the activity of TNF and IL-23 and a few other items in there as well. So it's kind of more of a shotgun type thing. It's sort of intracellular. It's inhibiting what the cells are producing that we don't want them to produce. And it works reasonably well in the skin. In fact, reasonably well is probably an understatement. It works reasonably quite well in the skin. It's a little less effective in the joint disease area, and it's not intended for patients who already have pre-existing joint damage. There's never been any proof that it slows down joint damage in psoriatic arthritis. That's one of the key elements of the clinical trials, not only to show that it helps the symptoms and the signs, but to see what the radiographs do over time, and hopefully are slowing down the process and having a true biological process. This was supposed to be my first slide, this little group. These are the things that don't work, basically. Everybody's tried for years, but we do commonly combine methotrexate and biologicals that there can be some synergistic effect there. In the old days, I can remember when there used to be papers published about using gold therapy in psoriatic arthritis, and supposedly it worked. But then on the other hand, people said it flared psoriasis. Same thing with Plaquenil. Sometimes it helped, but it could flare your psoriasis. The flutamide is the second best of methotrexate. Only reason we ever use that is because the insurance companies insist that we use that and fail on that before we can give a biological, which is bunk. If you were the senator's kid, you would not have to go through those hoops. Make this work?
I don't know.
I just thought I'd show you this little video I found on the internet. We may have to play it a couple times if we can make it work. Basically what this is showing are different cells in the sequence of our immunological development inside our cells, and the various cells that are involved